Hello and welcome. We have a very important show for you tonight. We're going to be talking about hearing loss, the elderly, and really how hearing loss affects people of all ages. We're looking tonight kind of from the broad perspective of some of the gaps in our healthcare, some of the really very surprising gaps, as I've learned, about hearing loss and coverage and accessibility for services. With me are three wonderful guests who all come from a different point of view. Sitting to my right is Mary Hartnett. Mary is the executive director of a commission, and you were appointed by Governor Dayton, as I understand it.
I was initially appointed by Governor Ventura.
Oh, so you've
I made it through
been
three
there
administrations.
quite a long time.
Yeah.
It's the Minnesota Commission on Deaf and...
It's the Commission of Deaf, Deafblind, and Hard of Hearing Minnesotans.
Thank you. So MNCDHH.
Sure.
Give us that title one more time.
It's the Commission of Deaf, Deafblind, and Hard of Hearing Minnesotans.
And before your work there, you have been the head of 3 nonprofits. She's won a lot of awards for her work with the deaf and hard of hearing and disabled. So it's lovely to have you.
Thank you, Mary.
Have you
Thanks
join
for
us.
inviting us.
My next guest is Dr. Sam Levine. Dr. Levine is at the University of Minnesota Medical School. He is a professor at the school, as well as a neurologist, and a man who is an expert with nerves and our hearing in our ears. And the proper name for your other title, Sam?
Is otolaryngologist.
I somehow didn't even want to try to memorize that. But it's fine to call you a neurologist also, correct?
It is.
Right. And how long have you been at the U?
Since 1986, but who's counting?
We're not counting. Dr. Levine told me there are only 1,000 neurologists in the whole country.
Yep.
And kind of a field that you feel is kind of a Rodney Dangerfield field, as you said.
We don't get no respect.
Yeah. Well, I had not heard of neurology, so I'm very glad we can learn more about what you do and
Thanks, Mary.
the ear. And finally with us is John Wodele, and maybe many of you, or most of you know John. He was the Director of Communications for Governor Ventura years ago. He's now with Duran Companies as Vice President of Marketing. He had a radio show back years ago with 1500
That's
AM.
correct.
Kind of an eclectic man about town.
I've been places, seen things.
And the interesting thing about John, he's on the board, on Mary's board, as one of the board members, and you're a man who's dealt with hearing loss for many years, but it was not diagnosed entirely until you were in your late 30s or 40?
That's correct, Mary. I've had hearing loss, experienced difficulty, hard of hearing for all of my, at least since a teenager in high school, and especially in college I noticed it a lot. And my remedy was to go to a family doctor and be told that you probably have wax in your ears. But fortunately, when I was 40 years old, I became so frustrated with the problem, and my family became frustrated with me for not dealing with it, that I went to the University of Minnesota, and they performed magic and helped me a lot.
Would you tell us the short story that you told me and us earlier about right away after you had your surgery and you were walking outside and on the street and you heard this noise?
Yeah. Fortunately for me and my problem, I had a condition called otosclerosis, and it was a condition that they could deal with and perform surgery and build me a new stapes, and so they did that actually in my right ear. And I remember when after I had the surgery, I was leaving the University of Minnesota Hospital and walking down the street on the campus of the University of Minnesota, and my ear was plugged with cotton and a big patch over my ear. And but I was walking down the street with my wife, and I said, What is that noise I hear? It's a kind of a rhythmic sound that seems to be following us. I would look behind me, and I'd stop, and so it's gone now. And then we started to walk again, and I stopped, and I said, "Oh my God, that's my feet hitting the ground." Mm-hmm. It's a miracle, and I'm forever grateful.
That's an example. I think it just brings it home to me in terms of what we don't understand about hearing loss, what we don't appreciate when we do have good hearing. So, well, the commission has some broad and big goals, don't you? Tell us a little bit about why we need the commission and what its mission is.
It's 20% of the population in this country have a hearing loss that's significant enough that it impedes their ability to communicate. And in 1985, a group of advocates got together and got legislation passed that required that there be a commission that was dedicated solely to looking at public policies that could improve barriers that are faced by people with hearing loss in education, healthcare, access to public services, technology. And since that time, we've worked with different communities and passed over 60, 70 pieces of legislation to improve the lives of people that are deaf, blind, and hard of hearing. Prior to that, in 1980, a group was started, the Deaf and Hard of Hearing Services Division was started around the time that a lot of the minority councils were started. And advocates came together, and they were providing direct services in 8 regions around the state. But then they saw that there needed to be public policies in place, and they couldn't do that if they were just part of and under the governor's watch. They needed to be able to be independent and to be able to develop those solutions. So that's why the commission is in place, and we're here. Actually, John has been pushing, and we're really thankful for his leadership. The governor appointed him, and is very concerned about age-related hearing loss as a public health issue. We do not have systems in place in the country that address hearing loss. Hearing loss hearing screening isn't part of a basic wellness check for seniors. Yet,
Which, if you think about that, I mean, just stop and think about that. That is, to me, shocking when 70% of seniors have hearing issues, hearing problems.
no, it is incredible, and there's research, and actually, Dr. Levine, you can speak to this better than I, but just the latest research shows the connection between dementia and hearing loss and falling and hearing loss, and those are huge cost drivers in our health system, and that we don't have a system in place that tests people for hearing loss, the seniors for hearing loss, and then gets them intervention to get them the help they need. And yet we're trying to address dementia and address falling, but we're not looking at some of the root causes
together. Could you comment on that and why you think we haven't been better at connecting the dots here?
Well, there's a lot of cost involved, and I think that a lot of the healthcare system is driven by that. I tell people that if you want to know why the healthcare costs are going up, all you have to do is look at me. I'm the guy that's driving the cost up. Because the things that we can do for hearing today are expensive, and they're good. They will improve the quality of your life. You will not live longer. And so it's hard to convince legislators to spend money on things that improve the quality of life but do not extend the life.
But if, as the new research shows, we're going to prevent falls and we're going to perhaps slow the process of dementia-related disorders, that's pretty convincing.
It is. There's increasing data for it, but it's difficult to do this because the National Institute of Deafness and Communication Disorders is underfunded, seriously underfunded. And it makes it difficult to collect the data and to establish the science. For example, we've talked about the connection that's been made between dementia and hearing loss. We know that there is a connection. We don't know the causal connection. Does deafness cause hearing loss? Or does the primary brain disorder cause both the hearing loss and the dementia? That we don't know yet.
And then the social part of it, if you are not hearing, you are more likely to withdraw, correct?
and to become depressed.
And be on your own, become depressed, as you were sharing earlier. And it's a big snowball, isn't it?
Absolutely, and actually the Institute of Medicine had a conference in January where Dr. Franklin, who is the researcher, who's the lead researcher on looking at dementia, looking at falling, et cetera, and he said he would argue that we don't need to say, does this cause it? It happens, and that we should be looking at low-cost solutions to try to get people the help they need. We need to get the screening to happen, and then we need to get low-cost solutions. I thought it was great. It was the first summit that we've had in the country that brought together people that are researchers and people that are practitioners, and then the Hearing Loss Association of America. That's really the consumer group, and that's, I think, what we bring to this, and John brings to this, is the consumer lens on, yes, the research is there. Yes, we know that these systems aren't in place, and that we should be, at least in Minnesota, and that's why we're here, to say that we should be bringing a group together to say, what can we do in Minnesota? What can we do to turn this curve and maybe do a pilot or get something, put a task force together? And one of your colleagues, Dr. James Bacala, is very interested, and I know the university is interested, but so are consumers, and I think it's a time that we can just seize and move forward to do something here.
It's interesting because in a couple of weeks I'm going to be going and getting a physical, an annual physical at a clinic here in Minneapolis. I'm going to be 67 years old in about a month. When I go for that physical, they're not going to ask me about my hearing.
I bet not either.
They're going to check me over from top to bottom, but they're going to skip this part. Does that make any sense?
Does
It
not
doesn't.
make sense,
No.
does it?
And it's so important because, especially in this day and age when noise is such a big part of our life and has been for a long time, and that can exacerbate a hearing, an already existing hearing problem, or create one. And our generation, the baby boom generation, which I'm at the forefront of, spent a lot of time abusing our ears, probably with music and various other things. When I was in the military, I was around airplanes all the time and abused my ears and made them worse than they would have been naturally. And it's a huge, huge problem. And we're going to have millions of people in this country walking around not being able to hear appropriately for a lot of things that you need to do. Little things, like driving even, when you don't hear sounds, hear sirens coming, that
Or you
kind
don't
of thing.
hear your blinker is still on and you should
Oh
turn
my
it
goodness,
off because...
I hear my wife saying, John, turn now off your blinker.
But that could cause an accident, couldn't it? If,
Absolutely,
Or just,
absolutely.
John, would describe your experience going to funerals, just even something as simple as that,
It's
and as common as that.
very uncomfortable situations that when you're hard of hearing, you tend to try to justify not experiencing. Take, for example, when you have a friend or a loved one that passes away and you are going to the wake, as we say. I try to avoid those situations, and I know people that still avoid them, and I experience people that can't hear, and I know right away because they avoid talking to you, or they smile while you're talking because everyone's talking in a hushed voice at the visitation, and then they're struggling to hear. And the sad thing about it is that so many times when you're in a situation like that, you're talking to people that you haven't seen for a long time, that they're family members and friends, and you do want to express your sympathy and do it in a comfortable way. Not hearing makes it very uncomfortable. It makes you smile and shake your head and probably answer, uh-huh,
and maybe
not
agree
knowing what
to
you're answering
something that
to.
you shouldn't be agreeing to,
Right.
right?
Right. I mean, those kinds of situations are just, they're
Myriad,
very,
aren't
very
there?
stressful for people that are hard of hearing.
I was wondering how important early identification is in terms of the medical. I mean, obviously the social piece is huge, as you're sharing some great examples, but what about medically? I mean, do we just find out, oh, you need hearing aids earlier, and it could weight, or are there some things that are being negatively impacting our hearing going on?
So there are common disorders of the ear that can be either surgically treated or some that require fairly aggressive medical management. As an example, if you have an asymmetric hearing loss, one ear hears well, the other ear hears poorly. For those conditions that present like that, many of our patients come in and say, I have a deaf ear. Well, why is that? Well, I don't know. And the workup should include often a scan of the head, and sometimes brain tumors can present this way. Missing something like that.
That should scare people right there, shouldn't
Yeah,
it?
right.
I
Absolutely.
mean, just that one piece.
And it's one of the reasons why the FDA requires that everyone who gets a hearing aid be medically cleared before they get one, to make sure that we don't miss things like brain tumors or cholesteatomas, skin diseases that affect the ear. These are things that are both medically treatable and surgically correctable, and you don't have to suffer with your hearing loss.
Would you recommend, and that's all so important to hear, would you recommend that people go have their hearing checked by a professional, not just their internist, by a neurologist?
There's not enough of us to go around, Mary. So
Well,
the
what
answer
would be
is
the
that
ideal? Tell us the ideal.
Well, first of all, the ideal is that the University of Minnesota is training doctors, and we're increasing the education about ear, nose, and throat disorders. And for the first time, we have an academic curriculum in this area, and we lecture both in basic sciences and in their clinical rotations.
So you're
we train it.
educating the family practice docs?
That's correct, so that they
as well
don't
as-
say things like John heard, which is, it's just wax.
Right.
Second, we have a group of professionals called audiologists who will measure your hearing and establish whether you have a hearing loss, and often if that hearing loss is amenable to hearing aids. And the audiologist can play a key role. Even Medicare recognizes that you need an audiogram or a hearing test done every year. And this is covered under your Medicare benefits.
Every year. So starting at what age would be?
So we
The
always
ideal.
assume 65,
65.
because
Yeah,
Because
you know,
that's the start.
I think this is interesting, and Mary mentioned something when she was speaking earlier of where our commission is going, and she's leading us, and that is that we would really like to do a pilot project, and that would be an ultimate goal for us. And I believe, I'm not aware that a project like we're planning has been done anywhere in the country. And if we can accomplish something to provide a study, working with a medical organization that would provide us the information we would need to take out and explain to people just what's going on out there with people that are hard of hearing, especially age-related. And Mary can probably speak
tell us
to
what
more detail on
how you envision this, because it sounds
First, we need to have a task
wonderful.
force to really, I think that there's so many players, and we're taking our model from the newborn hearing screening group that started years ago. There was definitive research that showed that if you identify a baby early on in the, that they can have typical linguistic development and meet developmental norms. And
If
with their hearing
identified
impairments,
early.
identified early, but we didn't have, hearing screening wasn't part of basic, it wasn't required at birth. Now hearing screening is required at birth, and a number of interventions are available. There's a hearing aid loaner bank that's available. There's sign language instruction in the home if the parents want it. There's all these supports that are evidence-based. And so we have research that shows all of the people that have hearing loss, but no system in place. So I think pulling together the medical community, putting together seniors themselves and looking at what they need, aligning ourselves with the Hearing Loss Association of America, and then also providers. Dr. Levine was talking about, this does not have to be expensive. I was at a party, a wedding party, one of my family members, and there was a guest there, and they asked me what I did, and he said he doesn't get a hearing test because he knows he can't afford a $3,000 hearing aid, so why bother? So I described, and Dr. Lin really is a proponent of this group called World Sound Solutions. He invited them, but there's other groups that are out there that have personal amplification systems that are around $300 that can be part of your cell phone that you can adjust yourself in one-on-one situations, in a noisy restaurant, and in different settings. And then, Dr. Levine, you one-upped me with an even cheaper solution. Do you want to describe that?
You can use the device with your phone that usually comes with ear plugs, and you can download software that will convert the microphone in the cell phone and use it as an amplifier and adjust the amplification.
Have you heard of this, John?
Just tonight.
Yeah.
Just tonight. So this is hot off the press.
Next time I go to a visitation, I'm going to bring my cell phone and the earphones and
Try it
put the
out.
microphone up to the people I'm talking to.
So Dr. Piccola has said that he would be part of our task force, and we wanted to put together and actually have subcommittees on, first, the screening part. What do we need to do for the screening? What's a model screening practice? And then to get, what are the interventions? What are some low-cost interventions that we can put in place that's affordable for people, that's easy to manipulate? And it's not just purchasing the hearing aids, because the research shows that when people get hearing aids, they don't use them because they don't know how to use them.
Yeah,
so putting policies in place that require that a certain amount of training be available, or that it be easy to get that training. So take off 3 or 4 big things, and that's what we want to do, and bring everybody together, and then move forward with a plan, and then hopefully take the lessons we learned from that and scale it out. Is that right?
That's right.
Okay.
Would this be something that you would just focus on seniors with the pilot project?
Absolutely.
Yes.
Okay.
Yes.
And what do we need to have happen before this becomes a project?
Well, we're just starting, and this is actually, Mary, this is so perfect. The board every 5 years, the commission goes out. We did 23 focus groups, interviewed 20 key leaders in the community, and then did a survey. Close 600 people participated in our process, and this was kind of rose to the fore. It rose to the top of one of the 5 big issues that we're going to be working on over the next 5 years. And so the board just voted on it in May, and we just started to have the discussion with the Department of Health, and then you called. So this is hot off the press. This is hot off the
Now
press.
somebody will be watching this show, a large medical organization, and call Mary and say, we'd like to work with you.
We'd like to be part of this. I'm curious if any other states are ahead of us in a bigger way. I mean, I'm guessing probably not.
Actually, when we were at the Institute of Medicine, which I believe Dr. Lin brought in everybody that he knew was working on issues. And Dr. Lin, I think, heard about what we had been doing in the state on a policy issue with kids and how effective and successful we had been. And then we were invited to be part of that. But then Dr. Piccola at the University of Minnesota is very well known, wrote an article in the Journal of American Medicine about hearing loss. So there's some good, smart people, Dr. Levine and John, that are from a policy perspective, that are waiting to do this. But there was nobody that was doing anything on a policy level. All the people were in the room, but nobody was connecting the dots.
Do we need legislative, budgetary kinds of support then to do it?
The study, no, I don't. I believe that we actually went to the legislature and said we wanted to do this, and we got funding to help to do part of the study, the initial part of it. The pilot itself, no, we won't have the funding, but to convene people, bring people together, and make the recommendations, we have the funding, and we're very excited to get started. So.
And perhaps a big company will step up and say, we want to work with you.
Yeah.
When you think of it impacting 70% of all seniors, I'm getting the signal we want to give folks some websites and email addresses. So if you are intrigued by this and want to learn more, I know we've covered a lot very fast. I'm going to have Mary share with you the information here because it's right up your alley here.
So for the policy information, you can contact the Commission of Deaf, Blind, and Hard of Hearing Minnesotans, and the website is there, www.mncdhh.org. And then our email address is on the site, mncdhh.info@state.min.us.
And then more as, there's another web page we want to put up too, or another. This is more services, right?
For services, for information about hearing aids, about equipment, about anything related to direct services related to hearing loss supports, The Deaf and Hard of Hearing Services Division at the Department of Human Services is fantastic. They have great services, and you can get their information from www.dhhsd.org, and their email is on the webpage there, or on the television screen right there.
Well, thank you,
Okay,
thank you.
right.
So policy first and then services, and both very, very important. We've just got a minute or so left. In terms of what we can do just when we're in interaction with our physicians, with our neighbors, start talking about the gaps here, start talking about the needs, right?
Yeah.
If you have a hearing loss that you've been thinking about doing something about, I put a plug in for the University of Minnesota physicians and the audiologist there. I have a hearing aid in one ear, and I use the University of Minnesota audiologist clinic for that. They do a wonderful job, just a wonderful job.
So don't be afraid of finding out you might have
That's right.
hearing loss.
You can
Either.
imagine the
I
weight.
think that's
you just
part
can't
of
imagine the weight that will take off your
yeah,
shoulders.
yeah. Well, thank you all so much for coming down, and
Thank you for inviting us. We're thrilled to be here.
well, it gets me excited about thinking we need to do more here to learn more and
Yeah.
move this along.
Yeah,
So
yeah.
good luck to you all
Well,
with
thank
the
you very
movement.
much.
Thanks,
Thank
Mary.
you.
You're welcome. Thank you for being with us. We'll be back again next week. Until then, have a good week.